Number 153613 CUST, Pearson, Berman PG Number 531 Title, Cozier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K / Normal Design Services of S4 Carlisle Publishing Services. Assessing the nails, continued. Skill 30-4. Assessment normal findings deviations from normal. 5. Inspect fingernail plate shape to determine its curvature and angle. Convex curvature, angle of nail plate about 160 degrees, Figure 30, 10A, spoon nail, Figure 30, 10B, clubbing, 180 degrees or greater, Figure 30, 10C and D, 6. Inspect fingernail and toenail texture. Smooth texture, excessive thickness or thinness or presence of grooves or furrows, bows lines, Figure 30, 10E, discolored or detached nail 7. Inspect fingernail and toenail bed color. Highly vascular and pink and light-skinned clients, dark-skinned clients may have brown or black pigmentation in longitudinal streaks. Bluish or purplish tint may reflect cyanosis, pallor may reflect poor arterial circulation. 8. Inspect tissues surrounding nails. Intact epidermis hangnails, paronychia, inflammation, 9. Perform Blanche test of capillary refill. Press the nails between your thumb and index finger, look for blanching and return of pink color to nail bed. Perform on at least one nail on each hand and foot. Prompt return of pink or usual color, generally less than 2 seconds, delayed return of pink or usual color, may indicate circulatory impairment. 10. Document findings in the client record using printed or electronic forms, or checklists supplemented by narrative notes when appropriate. Evaluation. Perform a detailed follow-up examination of other systems, based on findings that deviated from expected or normal for the client. Relate findings to previous assessment data if available. Report significant deviations from expected or normal to the primary care provider. Home care considerations assessing the nails. If indicated, teach the client or family member about proper nail care, including how to trim and shape the nails to avoid paronychia. To avoid cutting the skin accidentally, file infant nails instead of clipping. If eyesight, fine motor control, or cognition prevents the client from safely trimming the nails, refer the client to a podiatrist or manicurist if the client requires assistance with nail care. Patient-centered care. Figure 30-11 Bones of the head. Coronal suture. Lacrimal bone, nasal bone. Nasal septum. Maxilla. Zygomatic bone. Mandible. Frontal bone. Sagittal suture, parietal bone. Lambdoid suture. Temporal bone, sphenoid bone. Occipital bone, temporomandibular joint, external acoustic meatus, mastoid process C1, atlas C2, axis C3 vertebra. Head. During assessment of the head, the nurse inspects and palpates simultaneously, and also auscultates. The nurse examines the skull, face, eyes, ears, nose, sinuses, mouth, and pharynx. Skull and face. There is a large range of normal shapes of skulls. A normal head size is referred to as normocephalic. If head size appears to be outside of the normal range, the circumference can be compared to standard size tables. Measurements more than 2 standard deviations from the norm for the age, sex, and race of the client are abnormal, and should be reported to the primary care provider. Names of areas of the head are derived from names of the underlying bones, frontal, parietal, occipital, mastoid process, mandible, maxilla, and zygomatic, figure 30-11. Lifespan considerations assessing the nails. Infants' newborns' nails grow very quickly, are extremely thin, and tear easily. Children bent, bruised, or ingrown toenails may indicate shoes that are too tight. Nail biting should be discussed with an adult family member, because it may be a symptom of stress. Older adults, the nails grow more slowly and thicken. Longitudinal bands commonly develop, and the nails tend to split. Bands across the nails may indicate protein deficiency. White spots, zinc deficiency. Spoon-shaped nails may indicate iron deficiency. Toenail fungus is more common and difficult to eliminate, although not dangerous to health. M30_berm 4360_10_SE_CH30.IND531 April 12, 11:03 a.m. Number 153613 CUST, Pearson, Berman PG Number 532 Title, Cozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. 532 Unit 7 Assessing Health. Many disorders cause a change in facial shape or condition. Kidney or cardiac disease can cause edema of the eyelids. Hyperthyroidism can cause exophthalmos, a protrusion of the eyeballs with elevation of the upper eyelids, resulting in a startled or staring expression. Hypothyroidism, or myxedema, can cause a dry, puffy face with dry skin, and coarse features, and thinning of scalp hair and eyebrows. Assessing the skull and face. Skill 30-5. Increased adrenal hormone production, or administration of steroids, can cause a round face with reddened cheeks, referred to as moon face, and excessive hair growth on the upper lips, chin, and sideburn areas. Prolonged illness, starvation, and dehydration can result in sunken eyes, cheeks, and temples. Skill 30-5 describes how to assess the skull and face. Lifespan considerations assessing the skull and face. Infants newborns delivered vaginally can have elongated, molded heads, which take on more rounded shapes after a week or two. Infants born by cesarean section tend to have smooth, rounded heads. The posterior fontanelle, soft spot, is about 1 cm 0.4 inches in size and usually closes by 8 weeks. The anterior fontanelle is larger, about 2 to 3 centimeters, 0.8 to 1.2 inches in size. It closes by 18 months. Newborns can lift their heads slightly and turn them from side to side. Voluntary head control is well established by 4 to 6 months. Assessment normal findings deviations from normal. 5. Inspect the skull for size, shape, and symmetry. Rounded, normocephalic and symmetric, with frontal, parietal, and occipital prominences, smooth skull contour. Lack of symmetry, increased skull size with more prominent nose and forehead, longer mandible, may indicate excessive growth hormone or increased bone thickness. 6. Inspect the facial features, example, symmetry of structures and of the distribution of hair. Symmetric or slightly asymmetric facial features, palpebral fissures equal in size, symmetric nasolabial folds. Increased facial hair, low hairline, thinning of eyebrows, asymmetric features, exophthalmos, myxedema facies, moon face. 7. Inspect the eyes for edema or hollowness. No edema, periorbital edema, sunken eyes. 8. Note symmetry of facial movements. Ask the client to elevate the eyebrows, frown, or lower the eyebrows, close the eyes tightly, puff the cheeks, and smile and show the teeth. Symmetric facial movements, asymmetric facial movements, example, I cannot close completely, drooping of lower eyelid and mouth, involuntary facial movements, i.e., tics or tremors. 9. Document findings in the client record using printed or electronic forms, or checklists supplemented by narrative notes when appropriate. Planning delegation. Due to the substantial knowledge and skill required, assessment of the skull and face is not delegated to UAP. However, many aspects are observed during usual care, and may be recorded by individuals other than the nurse. Abnormal findings must be validated and interpreted by the nurse. Interprofessional practice. Assessing the skull and face is within the scope of practice of many healthcare providers other than nurses. Although these other providers may verbally communicate their findings and plan to healthcare team members, the nurse must also know where to locate their documentation in the client's medical record. Equipment. None. Implementation performance. 1. Prior to performing the procedure, Introduce self and verify the client's identity using agency protocol. Explain to the client what you are going to do, why it is necessary, and how he or she can participate. Discuss how the results will be used in planning further care or treatments. 2. Perform hand hygiene and observe other appropriate infection prevention procedures. 3. Provide for client privacy. 4. Inquire if the client has any history of the following: past problems with lumps or bumps, itching, scaling, or dandruff, history of loss of consciousness, dizziness, seizures, headache, facial pain, or injury, when and how any lumps occurred, length of time any other problem existed, any known cause of problem, associated symptoms, treatment, and recurrences. Evaluation: perform a detailed follow-up examination of other systems, based on findings that deviated from expected or normal for the client. Relate findings to previous assessment data if available. Report deviations from expected or normal findings to the primary care provider. M30_BERM 4362_10_SE_CH30.IND 532 April 12, 11:03 a.m. Chapter 30 Health Assessment 533. Number 153613 CUST, Pearson, Berman PG Number 533 Title, Cozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K/Normal Design Services of S4 Carlisle Publishing Services. And near vision require correction, 2 lenses, bifocals, are required. Astigmatism, an uneven curvature of the cornea that prevents horizontal and vertical rays from focusing on the retina, is a common problem that may occur in conjunction with myopia and hyperopia. Astigmatism may be corrected with glasses or surgery. 3 types of eye charts are available to test visual acuity, figure 30 to 14. People with denominators of 40 or more on the Snellen chart with or without corrective lenses need to be referred to an optometrist or ophthalmologist. Common inflammatory visual problems that nurses may encounter in clients include conjunctivitis, dacrocystitis, hordeolum, iritis, and contusions or hematomas of the eyelids and surrounding structures. Conjunctivitis, inflammation of the bulbar and palpebral conjunctiva, may result from foreign bodies, chemicals, allergenic agents, bacteria, or viruses. Redness, itching, tearing, and mucopurulent discharge occur. During sleep, the eyelids may become encrusted and matted together. Dacrocystitis, inflammation of the lacrimal sac, is manifested by tearing and a discharge from the nasolacrimal duct. Hordeolum, STI, is a redness, swelling, and tenderness of the hair follicle and glands that empty at the edge of the eyelids. Iritis, inflammation of the iris, may be caused by local or systemic infections and results in pain, tearing, and photophobia, sensitivity to light. Contusions or hematomas are black eyes resulting from injury. Cataracts tend to occur in individuals over 65 years old, although they may be present at any age. This opacity of the lens or its capsule, which blocks light rays, is frequently removed and replaced by a lens implant. Cataracts may also occur in infants due to a malformation of the lens, if the mother contracted rubella in the first trimester of pregnancy. Glaucoma, a disturbance in the circulation of aqueous fluid, which causes an increase in intraocular pressure, is the most frequent cause of blindness in people over age 40, although it can occur at younger ages. It can be controlled if diagnosed early. Danger signs of glaucoma include blurred or foggy vision, loss of peripheral vision, difficulty focusing on close objects, difficulty adjusting to dark rooms, and seeing rainbow-colored rings around lights. Upper eyelids that lie at or below the pupil margin are referred to as ptosis, and are usually associated with aging, edema from drug allergy, or systemic disease, example, kidney disease, congenital lid muscle. Eyes and vision. To maintain optimum vision, people need to have their eyes examined regularly throughout life. It is recommended that people under age 40 have their eyes tested every 3 to 5 years, or more frequently if there is a family history of diabetes, hypertension, blood dyscrasia, or eye disease, example, glaucoma. After age 40, an eye examination is recommended every 2 years. Examination of the eyes includes assessment of the external structures, visual acuity, the degree of detail the eye can discern in an image, ocular movement, and visual fields, the area an individual can see when looking straight ahead. Most eye assessment procedures involve inspection. Consideration is also given to developmental changes and to individual hygienic practices if the client wears contact lenses or has an artificial eye. For the anatomic structures of the eye, see Figure 30 to 12 and Figure 30 to 13. Many people wear eyeglasses or contact lenses to correct common refractive errors of the lens of the eye. These errors include myopia, nearsightedness, hyperopia, farsightedness, and presbyopia, loss of elasticity of the lens, and thus loss of ability to see close objects. Presbyopia begins at about 45 years of age. People notice that they have difficulty reading newsprint when both far. Figure 30 to 12 the external structures and lacrimal apparatus of the left eye. Inner canthus caruncle. Lacrimal canaliculi, canals. Lacrimal sac. Puncta. Nasolacrimal duct orifice of nasolacrimal duct. Pupil iris sclera. Outer canthus. Lacrimal ducts. Lacrimal gland. Bony orbital margin. Figure 30 to 13 anatomic structures of the right eye, lateral view. Bulbar conjunctiva. Optic nerve. Ciliary body superior rectus muscle ciliary process. Macula and fovea centralis. Retina choroid sclera inferior rectus muscle. Posterior chamber. Anterior chamber. Pupil. Cornea. Lens iris. Optic disc. Bulbar conjunctiva palpebral conjunctiva. Upper eyelid. Palpebral fissure lower eyelid. M30_Berm 4360_10_SE_CH30.IND533 April 12, 11:03 a.m. Number 153613 CUST, Pearsono, Berman PG Number 534 Title, Cozier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K /Normal Design Services of S4 Carlisle Publishing Services. 534 Unit 7 Assessing Health. Dysfunction, neuromuscular disease, example, myasthenia gravis, and third cranial nerve impairment. Eversion, an outturning of the eyelid, is called ectropion. Inversion, an inturning of the lid, is called entropion. These abnormalities are often associated with scarring injuries or the aging process. Pupils are normally black, are equal in size, about 3 to 7 millimeters in diameter, and have round, smooth borders. Cloudy pupils are of 10 indicative of cataracts. Mydriasis, enlarged pupils, may indicate injury or glaucoma, or result from certain drugs, example, atropine. Figure 30 to 14 3 types of eye charts. Left, the preschool children's chart. Center, the Snellen standard chart. Right, Snellen e-chart for clients unable to read. Right, Roman Sotola/Shutterstock. Cocaine, amphetamines. Meiosis, constricted pupils, may indicate an inflammation of the iris or result from such drugs as morphine/heroin and other narcotics, barbiturates, or pilocarpine. It is also an age-related change in older adults. Anisocoria, unequal pupils, may result from a central nervous system disorder, however, slight variations may be normal. The iris is normally flat and round. A bulging toward the cornea can indicate increased intraocular pressure. Skill 30 to 6 describes how to assess a client's eye structures and visual acuity. Planning place the client in an appropriate room for assessing the eyes and 6 shown. The nurse must be able to control natural and overhead lighting during some portions of the examination. Delegation. Due to the substantial knowledge and skill required, assessment of the eyes and vision is not delegated to UAP. However, many aspects are observed during usual care and may be recorded by individuals other than the nurse. Abnormal findings must be validated and interpreted by the nurse. Interprofessional practice. Assessing the eyes and vision may be within the scope of practice of other healthcare providers. Although these providers may verbally communicate their findings and plan to other healthcare team members, the nurse must also know where to locate their documentation in the client's medical record. Equipment millimeter ruler penlight Snellen, or e-chart opaque card. Assessing the eye structures and visual acuity. Skill 30-6. M30_Berm 4362_10_SE_CH30.IND534 April 12, 11:03 a.m. Chapter 30 Health Assessment 535. Number 153613 CUST, Pearsono, Berman PG Number 535 Title, Cozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K/Normal Design Services of S4 Carlisle Publishing Services. Continued on page 536. Assessing the eye structures and visual acuity, continued. Skill 30-6. Implementation Performance 1. Prior to performing the procedure, introduce self and verify the client's identity using agency protocol. Explain to the client what you are going to do, why it is necessary, and how he or she can participate. Discuss how the results will be used in planning further care or treatments. 2. Perform hand hygiene, apply gloves, and observe other appropriate infection prevention procedures. 3. Provide for client privacy. 4. Inquire if the client has any history of the following: family history of diabetes, hypertension, blood dyscrasia, or eye disease, injury, or surgery. Client's last visit to a provider who specify Cali assessed the eyes, example, ophthalmologist or optometrist, current use of eye medications, use of contact lenses or eyeglasses, hygienic practices for corrective lenses, current SYMP toms of eye problems, example, changes in visual acuity, blurring of vision, tearing, spots, photophobia, itching, or pain. Assessment normal findings deviations from normal. External eye structures. 5. Inspect the eyebrows for hair distribution and alignment and skin quality and movement. Ask client to raise and lower the eyebrows. Hair evenly distributed, skin intact, eyebrows symmetrically aligned, equal movement. Loss of hair, scaling and flakiness of skin, unequal alignment and movement of eyebrows. 6. Inspect the eyelashes for evenness of distribution and direction of curl. Equally distributed, curled, slightly outward, turned inward. 7. Inspect the eyelids for surface characteristics, example, skin quality and texture, position in relation to the cornea, ability to blink and frequency of blinking. Inspect the lower eyelids while the client's eyes are closed. 8. Remove and discard gloves. Perform hand hygiene. Skin intact, no discharge, no discoloration. Lids close symmetrically. Approximately 15 to 20 involuntary blinks per minute, bilateral blinking when lids open, no visible sclera above corneas, and upper and lower borders of cornea are slightly covered. Redness, swelling, flaking, crusting, plaques, discharge, nodules, lesions, lids close asymmetrically, incompletely, or painfully rapid, monocular, absent or infrequent blinking, ptosis, ectropion, or entropion, rim of sclera visible between lid and iris. External eye structures. 9. Inspect the bulbar conjunctiva, that lying over the sclera, for color, texture, and the presence of lesions. Transparent, capillaries sometimes evident, sclera appears white, darker or yellowish, and with small brown macules in dark-skinned clients. Jaundiced sclera, example, in liver disease, excessively pale sclera, example, in anemia, reddened sclera, marijuana use, rheumatoid disease, lesions or nodules, may indicate damage by mechanical, chemical, allergenic, or bacterial agents. 10. Inspect the cornea for clarity and texture. Ask the client to look straight ahead. Hold a pen light at an oblique angle to the eye, and move the light slowly across the corneal surface. Transparent, shiny, and smooth, details of the iris are visible in older people. A thin, grayish-white ring around the margin, called arcus senilis, may be evident. Opaque, surface not smooth, may be the result of trauma or abrasion. Arcus senilis in clients under age 40. 11. Inspect the pupils for color, shape, and symmetry of size. Pupil charts are available in some agencies. See for variations in pupil diameters. Black in color, equal in size, normally 3 to 7 mm in diameter, round, smooth border, iris flat and round. Cloudiness, mydriasis, miosis, anisocoria, bulging of iris toward cornea. 12. Assess each pupil's direct and consensual reaction to light to determine the function of the third, oculomotor, and fourth, trochlear, cranial nerves. Partially darken the room. Ask the client to look straight ahead. Using a pen light and approaching from the side, shine a light on the pupil. Observe the response of the illuminated pupil. It should constrict, direct response. Shine the light on the pupil again, and observe the response of the other pupil. It should also constrict, consensual response. Illuminated pupil constricts, direct response, non-illuminated pupil constricts, consensual response, response is brisk. Neither pupil constricts. Unequal responses. Response is sluggish absent responses. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 variations in pupil diameters in millimeters. M30_Berm 4362_10_SE_CH30.IND 535 April 12, 11:03 a.m. Number 153613 CUST, Pearsono, Berman PG number 536 title, Cozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K /Normal Design Services of S4 Carlisle Publishing Services. 536 Unit 7 Assessing Health. Assessing the eye structures and visual acuity, continued. Skill 30-6. Assessment normal findings deviations from normal. 13. Assess each pupil's reaction to accommodation. Hold an object, a pen light or pencil, about 10 centimeters 4 inches from the bridge of the client's nose. Ask the client to look first at the top of the object, and then at a distant object, example, the far wall, behind the pen light. Alternate the gaze from the near to the far object. Observe the pupil response. Next, ask the client to look at the near object, and then move the pen light or pencil toward the client's nose. Pupils constrict when looking at near object, pupils dilate when looking at far object. Pupils converge when near object is moved toward nose. To record normal assessment of the pupils, use the abbreviation PERLA, pupils equally round and react to light and accommodation. One or both pupils fail to constrict, dilate, or converge. Visual fields 14. Assess peripheral visual fields to determine function of the retina, and neuronal visual pathways to the brain and second, optic, cranial nerve. Have the client sit directly facing you at a distance of 60 to 90 centimeters, 2 to 3 feet. Ask the client to cover the right eye with a card and look directly at your nose. Cover or close your eye directly opposite the client's covered eye, i.e., your left eye, and look directly at the client's nose. Hold an object, example, a pen light or pencil, in your fingers, extend your arm, and move the object into the visual field from various points in the periphery. The object should be at an equal distance from the client and yourself. Ask the client to tell you when the moving object is first spotted. A. To test the temporal field of the left eye, extend and move your right arm in from the client's right periphery. B. To test the upward field of the left eye, extend and move the right arm down from the upward periphery. C. To test the downward field of the left eye, extend and move the right arm up from the lower periphery. When looking straight ahead, client can see objects in the periphery visual field smaller than normal, possible glaucoma, 1/2 vision in one or both eyes, possible nerve damage. Temporally, peripheral objects can be seen at right angles, 90 degrees, to the central point of vision. The upward field of vision is normally 50 degrees, because the orbital ridge is in the way. The downward field of vision is normally 70 degrees, because the cheekbone is in the way. The nasal field of vision is normally 50 degrees away from the central point of vision, because the nose is in the way. D. To test the nasal field of the left eye, extend and move your left arm in from the periphery. Repeat the above steps for the right eye, reversing the process. Extraocular muscle tests. 15. Assess 6 ocular movements to determine eye alignment and coordination. Stand directly in front of the client and hold the penlight at a comfortable distance, such as 30 centimeters 1 foot in front of the client's eyes. Ask the client to hold the head in a fixed position facing you and to follow the movements of the penlight with the eyes only. Both eyes coordinated, move in unison, with parallel alignment eye movements not coordinated or parallel. One or both eyes fail to follow a penlight in specific directions, example, strabismus, cross-eye, nystagmus, rapid involuntary rhythmic eye movement, other than at end point may indicate neurologic impairment. Assessing the client's left peripheral visual field. M30_BERM 4362_10_SE_CH 30.IND 536 April 12, 11:03 a.m. Chapter 30 Health Assessment 537. Number 153613 CUST, Pearson, Berman PG Number 537 Title, Cozier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K_Normal. Design Services of S4 Carlisle Publishing Services. Assessing the eye structures and visual acuity, continued. Skill 30-6. Continued on page 538. Assessment normal findings deviations from normal. Move the penlight in a slow, orderly manner through the 6 cardinal fields of gaze, that is, from the center of the eye along the lines of the arrows in and back to the center. Stop the movement of the penlight periodically so that nystagmus can be detected. 16. Assess for location of light reflex by shining penlight on the corneal surface, Hirschberg test. Light falls symmetrically, example, at 6 o'clock on both pupils, light falls off-center on one eye. 17. Have client fixate on a near or far object. Cover one eye and observe for movement in the uncovered eye cover test. Uncovered eye does not move if misalignment is present. When dominant eye is covered, the uncovered eye will move to focus on object. Visual acuity 18. If the client can read, assess near vision by providing adequate lighting and asking the client to read from a magazine or newspaper held at a distance of 36 centimeters 14 inches. If the client normally wears corrective lenses, the glasses or lenses should be worn during the test. The document must be in a language the client can read. Able to read newsprint, difficulty reading newsprint unless due to aging process. 19. Assess distance vision by asking the client to wear corrective lenses, unless they are used for reading only, i.e., for distances of only 36 centimeters, 14 inches. 20/20ths vision on Snellen type chart denominator of 40 or more on Snellen type chart with corrective lenses. Ask the client to stand or sit 6 m, 20 feet, from a Snellen or character chart, cover the eye not being tested, and identify the letters or characters on the chart. Take 3 readings, right eye, left eye, both eyes. Record the readings of each eye and both eyes, i.e., the smallest line from which the person is able to read 1/2 or more of the letters. 1 superior rectus, CN3. 6 inferior oblique, CN3. 1 superior rectus, CN3. 5 medial rectus, CN3. 2 lateral rectus, CN6. 2 lateral rectus, CN6. 3 inferior rectus, CN3. For superior oblique, CN4. 3 inferior rectus, CN3, the 6 muscles that govern eye movement. Testing distance vision. Clinical alert. A Rosenbaum eye chart may be used to test near vision. It consists of paragraphs of text or characters in different sizes. Be sure the client has a literacy level appropriate for the text used. M30_Berm 4360_10_SE_CH30.IND537 April 12, 11:03 a.m. Number 153613 CUST, Pearson Berman PG number 538 title, Cozier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. 538 Unit 7 Assessing Health. Assessing the eye structures and visual acuity, continued. Skill 30-6. Lifespan considerations assessing the eyes and vision. Infants 4 weeks of age should gaze at and follow objects. Ability to focus with both eyes should be present by 6 months of age. Infants do not have tears until about 3 months of age. Visual acuity is about 20/300 at 4 months and progressively improves. Children epicanthal folds, common in individuals of Asian cultures, may cover the medial canthus and cause eyes to appear misaligned. Epicanthal folds may also be seen in young children of any race before the bridge of the nose begins to elevate. Preschool children's acuity can be checked with picture cards or the Snellen e-chart. Acuity should approach 20/20ths by 6 years of age. A cover test and the corneal light reflex, Hirschberg, test should be conducted on young children to detect misalignment early and prevent amblyopia. Always perform the acuity test with glasses on if a child has prescription lenses. Children should be tested for color vision deficit. From 8% to 10% of Caucasian males, and from 0.5% to 1% of Caucasian females have this deficit. It is much less common in non-Caucasian children. The Ishihara or Hardy-Rand-Riddler test can be used. Older adults' visual acuity decreases as the lens of the eye ages and becomes more opaque and loses elasticity. The ability of the iris to accommodate to darkness and dim light diminishes. Peripheral vision diminishes. The adaptation to light, glare, and dark decreases. Accommodation to far objects often improves, but accommodation to near objects decreases. Color vision declines. Older people are less able to perceive purple colors and to discriminate pastel colors. Many older adults wear corrective lenses. They are most likely to have hyperopia. Visual changes are due to loss of elasticity, presbyopia, and transparency of the lens. Assessment normal findings deviations from normal. At the end of each line of the chart are standardized numbers, fractions. The top line is 20/200. The numerator, top number BER, is always 20, the distance the person stands from the chart. The denominator, bottom number, is the distance from which the normal eye can read the chart. Therefore, a person who has 20/40ths vision can see at 20 feet from the chart what a normal-sighted person can see at 40 feet from the chart. Visual acuity is recorded as SC, without correction, or CC with correction. You can also indicate how many letters were misread in the line. Example, visual acuity 20/40ths, 2C. C indicates that 2 letters were misread in the 20/40ths line by a client wearing corrective lenses. 20. If the client is unable to see even the top line, 20/200, of the Snellen type chart, perform selected vision tests, box 30-6. Perform a detailed follow-up examination of other systems, based on findings that deviated from expected or normal for the client. Relate findings to previous assessment data if available. 21. Document findings in the client record as ING printed or electronic forms, or checklists supplemented by narrative notes when appropriate. Report deviations from expected or normal findings to the primary care provider. Individuals with denominators of 40 or more on the Snellen or character chart, with or without corrective lenses, may need to be referred to an optometrist or ophthalmologist. M30_Berm 4360-10_SE_CH30.IND 538 April 12, 11:03 a.m. Chapter 30 Health Assessment 539. Number 153613 CUST, Pearson O. Berman PG Number 539 Title, Cozier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K/Normal Design Services of S4 Carlisle Publishing Services. Ears and Hearing. Assessment of the ear includes direct inspection and palpation of the external ear, inspection of the internal parts of the ear by an otoscope, instrument for examining the interior of the ear, especially the eardrum, consisting essentially of a magnifying lens and a light, and determination of auditory acuity. The ear is usually assessed during an initial physical examination. Periodic reassessments may be necessary for long-term clients or those with hearing problems. In some practice settings, only advanced practice nurses perform otoscopic examinations. The ear is divided into three parts: external ear, middle ear, and inner ear. Many of the structures discussed next are illustrated in Figure 30 to 15. The external ear includes the auricle or pinna, the external auditory canal, and the tympanic membrane, or lifespan considerations assessing the eyes and vision, continued. External eye structures. The skin around the orbit of the eye may darken. The eyeball may appear sunken because of the decrease in orbital fat. Skin folds of the upper lids may seem more prominent, and the lower lids may sag. The eyes may appear dry and dull because of the decrease in tear production from the lacrimal glands. A thin, grayish-white arc or ring, arcus senilis, appears around part or all of the cornea. It results from an accumulation of a lipid substance on the cornea. The cornea tends to cloud with age. The iris may appear pale with brown discolorations as a result of pigment degeneration. The conjunctiva of the eye may appear paler than that of younger adults, and may take on a slightly yellow appearance because of the deposition of fat. Pupil reaction to light and accommodation is normally symmetrically equal, but may be less brisk. The pupils can appear smaller in size, unequal, and irregular in shape because of sclerotic changes in the iris. Home care considerations assessing the eyes and vision. When making a home visit, take your equipment and charts with you. Also include a tape measure to lay out the 6 meters, 20 feet, needed for distance vision testing. Use the assessment as an opportunity to reinforce proper eye care and need for regular vision testing. Patient-centered care. Box 30 to 6 performing selected vision tests. Light perception, LP, shine a pen light into the client's eye from a lateral position, and then turn the light off. Ask the client to tell you when the light is on or off. If the client knows when the light is on or off, the client has light perception, and the vision is recorded as LP. Hand movements, H/M. Hold your hand 30 centimeters 1 foot from the client's face, and move it slowly back and forth, stopping it periodically. Ask the client to tell you when your hand stops moving. If the client knows when your hand stops moving, record the vision as H/M 1 foot. Counting fingers, C/F. Hold up some of your fingers 30 centimeters 1 foot from the client's face, and ask the client to count your fingers. If the client can do so, note on the vision record C/F 1 foot. Figure 30 to 15 anatomic structures of the external, middle, and inner ear. Tragus. Lobule. External auditory canal. Tympanic membrane eustachian tube round window. Cochlea. Vestibule. Branches of auditory nerve. Semicircular canal stapes. Incus. Malleus auditory ossicles temporal bone pinna. External ear. Middle ear. Inner ear. Eardrum. Landmarks of the auricle include the lobule, earlobe, helix, the posterior curve of the auricle's upper aspect, antihelix, the anterior curve of the auricle's upper aspect, tragus, the cartilaginous protrusion at the entrance to the ear canal, triangular fossa, a depression of the antihelix, and external auditory meatus, the entrance to the ear canal. Although not part of the ear, the mastoid, a bony prominence behind the ear, is another important landmark. The external ear canal is curved, is about 2.5 centimeters, 1 inch, long in the adult, and ends at the tympanic membrane. It is covered with skin that has many fine hairs, glands, and nerve endings. The glands secrete cerumen, earwax, which lubricates and protects the canal. M30_Berm 4360_10_SE_CH30.IND539 April 12, 11:03 a.m. Number 153613 CUST, Pearson, Berman PG Number 540 Title, Cozier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K/Normal Design Services of S4 Carlisle Publishing Services. 540 Unit 7 Assessing Health. 2. The sound waves vibrate the tympanic membrane and reach the ossicles. 3. The sound waves travel from the ossicles to the opening in the inner ear, oval window. 4. The cochlea receives the sound vibrations. 5. The stimulus travels to the auditory nerve, the 8th cranial nerve, and the cerebral cortex. Bone-conducted sound transmission occurs when skull bones transport the sound directly to the auditory nerve. Audiometric evaluations, which measure hearing at various decibels, are recommended for children and older adults. A common hearing deficit with age is loss of ability to hear high-frequency sounds, such as F, S, SH, and PH. This neurosensory hearing deficit does not respond well to use of a hearing aid. Conductive hearing loss is the result of interrupted transmission of sound waves through the outer and middle ear structures. Possible causes are a tear in the tympanic membrane, or an obstruction, due to swelling or other causes, in the auditory canal. Sensory neural hearing loss is the result of damage to the inner ear, the auditory nerve, or the hearing center in the brain. Mixed hearing loss is a combination of conduction and sensory neural loss. Skill 30-7 describes how to assess the ears and hearing. The curvature of the external ear canal differs with age. In the infant and toddler, the canal has an upward curvature. By age 3, the ear canal assumes the more downward curvature of adulthood. The middle ear is an air-filled cavity that starts at the tympanic membrane and contains 3 ossicles, bones of sound transmission: the malleus, hammer, the incus, anvil, and the stapes, stirrups. The eustachian tube, another part of the middle ear, connects the middle ear to the nasopharynx. The tube stabilizes the air pressure between the external atmosphere and the middle ear, thus preventing rupture of the tympanic membrane and discomfort produced by marked pressure differences. The inner ear contains the cochlea, a seashell-shaped structure essential for sound transmission and hearing, and the vestibule and semicircular canals, which contain the organs of equilibrium. Sound transmission and hearing are complex processes. In brief, sound can be transmitted by air conduction or bone conduction. Air conducted transmission occurs by this process. 1. A sound stimulus enters the external canal and reaches the tympanic membrane. Planning it is important to conduct the ear and hearing examination in an area that is quiet. In addition, the location should allow the client to be positioned sitting or standing at the same level as the nurse. Delegation. Due to the substantial knowledge and skill required, assessment of the ears and hearing is not delegated to UAP. However, many aspects are observed during usual care and may be recorded by individuals other than the nurse. Abnormal findings must be validated and interpreted by the nurse. Interprofessional practice. Assessing the ears and hearing are within the scope of practice for many healthcare providers other than nurses. For example, audiologists and physician assistants may check the client's hearing. Although these providers may verbally communicate their findings and plan to other healthcare team members, the nurse must also know where to locate their documentation in the client's medical record. Equipment: otoscope with several sizes of ear specula tuning fork. Implementation. Performance 1. Prior to performing the procedure, introduce self and verify the client's identity using agency protocol. Explain to the client what you are going to do, why it is necessary, and how he or she can participate. Discuss how the results will be used in planning further care or treatments. 2. Perform hand hygiene and observe other appropriate infection prevention procedures. 3. Provide for client privacy. 4. Inquire if the client has any history of the following: family history of hearing problems or loss, presence of ear problems or pain, medication history, especially if there are complaints of ringing in the ears, tinnitus, hearing difficulty, its onset, factors contributing to it, and how it interferes with activities of daily living, use of a corrective hearing device, when and from whom it was obtained. 5. Position the client comfortably, seated if possible. Assessing the ears and hearing. Skill 30-7. M30_Berm4362_10_SE_CH30.IND540 April 12, 11:03 a.m. Chapter 30 Health Assessment 541. Number 153613 CUST, Pearson O. Berman PG Number 541 Title, Cozier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Continued on page 542. Assessing the ears and hearing, continued. Skill 30-7. Assessment: normal findings, deviations from normal. Oracles 6. Inspect the oracles for color, symmetry of size, and position. To inspect position, note the level at which the superior aspect of the oracle attaches to the head in relation to the eye. Color: same as facial skin. Symmetrical oracle aligned with outer canthus of eye, about 10 degrees, from vertical. Bluish color of earlobes, example, cyanosis, pallor, example, frostbite, excessive redness, inflammation or fever, asymmetry, low set ears, associated with a congenital abnormality, such as Down syndrome. 7. Palpate the oracles for texture, elasticity, and areas of tenderness. Gently pull the oracle upward, downward, and backward. Fold the pinna forward, it should recoil. Push in on the tragus. Apply pressure to the mastoid process. Mobile, firm, and not tender, pinna recoils after it is folded. Lesions, example, cysts, flaky, scaly skin, example, seborrhea, tenderness when moved or pressed, may indicate inflammation or infection of external ear. External ear canal and tympanic membrane. 8. Inspect the external ear canal for cerumen, skin lesions, pus, and blood. Distal third contains hair follicles and glands. Dry cerumen, grayish tan color, or sticky, wet cerumen in various shades of brown. Redness and discharge. Scaling, excessive cerumen obstructing canal. 9. Visualize the tympanic membrane using an otoscope. Attach a speculum to the otoscope. Use the largest diameter that will fit the ear canal without causing discomfort. Rationale: this achieves maximum vision of the entire ear canal and tympanic membrane. Tip the client's head away from you and straighten the ear canal. For an adult, straighten the ear canal by pulling the pinna up and back. Rationale: straightening the ear canal facilitates vision of the ear canal and the tympanic membrane. 10 degrees. Normal alignment. 10 degree. Low set ears and deviation in alignment of the ears. Normal position. Straightening the ear canal of an adult by pulling the pinna up and back. M30_Berm4362_10_SE_CH30.IND541 April 12, 11:03 a.m. Number 153613 CUST, Pearson, Berman PG Number 542 Title, Cozier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. 542 Unit 7 Assessing Health. Assessing the ears and hearing, continued. Skill 30-7. Assessment normal findings deviations from normal. Hold the otoscope either A. right side up, with your fingers between the otoscope handle and the client's head, or B. upside down, with your fingers and the ulnar surface of your hand against the client's head. Rationale: this stabilizes the head and protects the eardrum and canal from injury if a quick head movement occurs. Gently insert the tip of the otoscope into the ear canal, avoiding pressure by the speculum against either side of the ear canal. Rationale: the inner 2/3 of the ear canal is bony. If the speculum is pressed against either side, the client will experience discomfort. 10. Inspect the tympanic membrane for color and gloss. Pearly gray color, semi-transparent pink to red, some opacity yellow amber white blue or deep red dull surface. Gross hearing acuity tests 11. Assess client's response to normal voice tones. If client has difficulty hearing the normal voice, proceed with the following tests. Normal voice tones audible, normal voice tones not audible. Example: requests nurse to repeat words or statements, leans toward the speaker, turns the head, cups the ears, or speaks in loud tone of voice. 11a. Perform the whisper test to assess high-frequency hearing. Able to repeat the phrases correctly in both ears, unable to repeat the phrases in one or both ears, have the client occlude one ear. Out of the client's sight, at a distance of 0.3 to 0.6 m, 1 to 2 feet, whisper a simple phrase such as "the weather is hot today." Ask the client to repeat the phrase. Repeat with the other ear using a different phrase. 11b. Tuning fork tests. Perform Weber's test to assess bone conduction by examining the lateralization, sideward transmission, of sounds. Hold the tuning fork at its base. Activate it by tapping the fork gently against the back of your hand near the knuckles, or by stroking the fork between your thumb and index fingers. It should be made to ring softly. Sound is heard in both ears or is localized at the center of the head. Weber negative. Sound is heard better in impaired ear, indicat ing a bone conductive hearing loss, or sound is heard better in ear without a problem, indicating a sensory neural disturbance. Weber positive. Place the base of the vibrating fork on top of the client's head, and ask where the client hears the noise. Conduct the Rinne test to compare air conduction to bone conduction. Inserting an otoscope. Placing the base of the tuning fork on the client's skull. Weber's test. M30_Berm 4362_10_SE_CH 30.IND 542 April 12, 11:03 a.m. Chapter 30 Health Assessment 543. Number 153613 CUST, Pearson, Berman PG Number 543 Title, Cozier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Assessing the ears and hearing, continued. Skill 30-7. 12. Document findings in the client record using printed or electronic forms, or checklists supplemented by narrative notes when appropriate. Rinne test tuning fork placement. A. Base of the tuning fork on the mastoid process. B. Tuning fork prongs placed in front of client's ear. Assessment normal findings deviations from normal. Hold the handle of the activated ton ing fork on the mastoid process of one ear A until the client states that the vibration can no longer be heard. Air conducted AC hearing is greater than bone conducted BC hearing, i.e., ACBC, positive Rinne. Bone conduction time is equal to or longer than the air conduction time, i.e., BCAC, or BC equals AC, negative Rinne. indicates a conductive hearing loss. Immediately hold the still vibrating fork prongs in front of the client's ear canal. B. Push aside the client's hair if necessary. Ask whether the client now hears the sound. Sound conducted by air is heard more readily than sound conducted by bone. The tuning fork vibrations conducted by air are normally heard longer. Evaluation. Perform a detailed follow-up examination of other systems, based on findings that deviated from expected or normal for the client. Relate findings to previous assessment data if available. Report deviations from expected or normal findings to the primary care provider. A.B. Home care considerations. Assessing the ears and hearing. Ensure that the examination is conducted in a quiet place. In particular, older adults will have difficulty accurately reporting results of hearing tests if excessive noise is present. If necessary, ask the adult present with an infant or child to assist in holding the child still during the examination. Patient-centered care. Lifespan considerations. Assessing the ears and hearing. Infants. To assess gross hearing, ring a bell from behind the infant, or have the parent call the child's name to check for a response. Newborns will quiet to the sound and may open their eyes wider. By 3 to 4 months of age, the child will turn head and eyes toward the sound. All newborns should be assessed for hearing prior to discharge from the hospital. Most states and many countries have a law or regulation requiring universal newborn hearing screening. Children. To inspect the external canal and tympanic membrane in children less than 3 years old, pull the pinna down and back. Insert the speculum only 0.6 to 1.25 centimeters, 0.25 to 0.5 inches. Perform routine hearing checks and follow up on abnormal results. In addition to congenital or infection-related causes of hearing loss, noise-induced hearing loss is becoming more common in adolescents and young adults as a result of exposure to loud music and prolonged use of headsets at extremely loud volumes. Weichbold, Halser, Newsley, and Stefan, 2012. Teach that music loud enough to prevent hearing. A normal conversation can damage hearing. Older adults. The skin of the ear may appear dry and be less resilient because of the loss of connective tissue. Increased coarse and wire-like hair growth occurs along the helix, antihelix, and tragus. The pinna increases in both width and length, and the earlobe elongates. Earwax is drier. The tympanic membrane is more translucent and less flexible. The intensity of the light reflex may diminish slightly. Sensory neural hearing loss occurs. Generalized hearing loss, presbycusis, occurs in all frequencies, although the first symptom is the loss of high-frequency sounds, the F, S, SH, and PH sounds. To such individuals, conversation can be distorted and result in what appears to be inappropriate or confused behavior. M30_Berm 4360_10_SE_CH30.IND543 April 12, 14, 11:03 a.m. Number 153613 CUST, Pearson, Berman PG. Number 544 Title, Cozier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. 544 Unit 7 Assessing Health. If the client reports difficulty or abnormality in smell, the nurse may test the client's olfactory sense by asking the client to identify common odors such as coffee or mint. This is done by asking the client to close the eyes and placing vials containing the scent under the client's nose. The nurse also inspects and palpates the facial sinuses, figure 30 to 16. Skill 30 to 8 describes how to assess the nose and sinuses. Nose and sinuses. A nurse can inspect the nasal passages very simply with a flashlight. However, a nasal speculum and a penlight, or an otoscope with a nasal attachment facilitates examination of the nasal cavity. Assessment of the nose includes inspection and palpation of the external nose. The upper third of the nose is bone, the remainder is cartilage, patency of the nasal cavities, and inspection of the nasal cavities. Figure 30 to 16. The facial sinuses. Maxillary sinuses. Sphenoid sinus. Ethmoid sinuses. Frontal sinuses. Supraorbital ridge. Maxillary sinus. Sphenoid sinus. Ethmoid sinuses. Frontal sinus. Lateral view, frontal view. Planning delegation. Due to the substantial knowledge and skill required, assessment of the nose and sinuses is not delegated to UAP. However, many aspects are observed during usual care and may be recorded by individuals other than the nurse. Abnormal findings must be validated and interpreted by the nurse. Interprofessional practice. Assessing the nose and sinuses may be within the scope of practice for healthcare providers other than nurses, such as physician assistants. Although these providers may verbally communicate their findings and plan to other healthcare team members, the nurse must also know where to locate their documentation in the client's medical record. Equipment: nasal speculum, flashlight/pen light. Implementation. Performance 1. Prior to performing the procedure, introduce self and verify the client's identity using agency protocol. Explain to the client what you are going to do, why it is necessary, and how he or she can participate. Discuss how the results will be used in planning further care or treatments. 2. Perform hand hygiene and observe other appropriate infection prevention procedures. 3. Provide for client privacy. 4. Inquire if the client has any history of the following: allergies, difficulty breathing through the nose, sinus infections, injuries to nose or face, nosebleeds, medications taken, changes in sense of smell. 5. Position the client comfortably, seated if possible. Assessment: normal findings, deviations from normal. Nose. 6. Inspect the external nose for any deviations in shape, size, or color, and flaring or discharge from the nares. Symmetric and straight, no discharge or flaring, uniform color. Asymmetric discharge from nares, localized areas of redness or presence of skin lesions. 7. Lightly palpate the external nose to determine any areas of tenderness, masses, and displacements of bone and cartilage. Not tender, no lesions, tenderness on palpation, presence of lesions. Assessing the nose and sinuses. Skill 30 to 8. M30_Berm 4362_10_SE_CH30.IND 544 April 12, 11:03 a.m. Chapter 30 Health Assessment 545. Number 153613 CUST, Pearson, Berman PG. Number 545. Title: Cozier and Herbs Fundamentals of Nursing 10 EC/M/Y/K/Normal Design Services of S4 Carlisle Publishing Services. Assessing the nose and sinuses, continued. Skill 30 to 8. Assessment: normal findings, deviations from normal. 8. Determine patency of both nasal cavities. Ask the client to close the mouth, exert pressure on one nares, and breathe through the opposite nares. Repeat the procedure to assess patency of the opposite nares. Air moves freely as the client breathes through the nares. Air movement is restricted in one or both nares. 9. Inspect the nasal cavities using a flashlight or a nasal speculum. Hold the speculum in your right hand to inspect the client's left nostril, and your left hand to inspect the client's right nostril. Tip the client's head back. Facing the client, insert the tip of the speculum about 1 cm (0.4 inches). Care must be taken to avoid pressure on the sensitive nasal septum. Inspect the lining of the nares and the integrity and the position of the nasal septum. 10. Observe for the presence of redness, swell growths, and discharge. Mucosa pink clear, watery discharge, no lesions. Mucosa red, edematous abnormal discharge, example, pus, presence of lesions, example, polyps. 11. Inspect the nasal septum between the nasal chambers. Nasal septum intact and in midline septum deviated to the right or to the left. Facial sinuses 12. Palpate the maxillary and frontal sinuses for tenderness. Not tenderness in one or more sinuses. 13. Document findings in the client record using printed or electronic forms or checklists supplemented by narrative notes when appropriate. Nasal septum middle turbinate middle meatus inferior turbinate. The nasal septum, inferior and middle turbinates of the nasal passage. Evaluation. Perform a detailed follow-up examination of other systems, based on findings that deviated from expected or normal for the client. Relate findings to previous assessment data if available. Report deviations from expected or normal findings to the primary care provider. Lifespan considerations assessing the nose and sinuses. Infants' a speculum is usually not necessary to examine the septum, turbinates, and vestibule. Instead, push the tip of the nose upward with the thumb, and shine a light into the nares. Ethmoid and maxillary sinuses are present at birth. Frontal sinuses begin to develop by 1 to 2 years of age, and sphenoid sinuses develop later in childhood. Infants and young children have fewer sinus problems than older children and adolescents. Children, a speculum is usually not necessary to examine the septum, turbinates, and vestibule. It might cause the child to be apprehensive. Instead, push the tip of the nose upward with the thumb, and shine a light into the nares. Ethmoid sinuses continue to develop until age 12. Cough and runny nose are the most common signs of sinusitis in preadolescent children. Adolescents may have headaches, facial tenderness, and swelling, similar to the signs seen in adults. Older adults, the sense of smell markedly diminishes, because of a decrease in the number of olfactory nerve fibers and atrophy of the remaining fibers. Older adults are less able to identify and discriminate odors. Nosebleeds may result from hypertensive disease or other arterial vessel changes. Mouth and oropharynx. The mouth and oropharynx are composed of a number of structures: lips, oral mucosa, the tongue and floor of the mouth, teeth and gums, hard and soft palate, uvula, salivary glands, tonsillar pillars, and tonsils. Anatomic structures of the mouth are shown in Figure 30 to 17. By age 25, most people have all their permanent teeth. For information about structures of the teeth, see Chapter 33. Normally, 3 pairs of salivary glands empty into the oral cavity, the parotid, submandibular, and sublingual glands. The parotid gland is the largest and empties through Stenson's duct opposite the second molar. The submandibular gland empties through Wharton's duct, which is situated on either side of the frenulum on the floor of the mouth. The sublingual salivary gland lies in the floor of the mouth, and has numerous openings. M30_Berm 4362_10_SE_CH30.IND 545 April 12, 11:03 a.m. Number 153613 CUST, Pearson O, Berman PG Number 546 Title, Cozier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. 546 Unit 7 Assessing Health. Dental caries, cavities, and periodontal disease, or pyorrhea, are the 2 problems that most frequently affect the teeth. Both problems are commonly associated with plaque and tartar deposits. Plaque is an invisible soft film that adheres to the enamel surface of teeth. It consists of bacteria, molecules of saliva, and remnants of epithelial cells and leukocytes. When plaque is unchecked, tartar, dental calculus, forms. Tartar is a visible, hard deposit of plaque and dead bacteria that forms at the gum lines. Tartar buildup can alter the fibers that attach the teeth to the gum, and eventually disrupt bone tissue. Periodontal disease is characterized by gingivitis, red, swollen gingiva, gum, bleeding, receding gum lines, and the formation of pockets between the teeth and gums. In advanced periodontal disease, the teeth are loose and pus is evident when the gums are pressed. Other problems nurses may see are glossitis, inflammation of the tongue, stomatitis, inflammation of the oral mucosa, and parotitis, inflammation of the parotid salivary gland. The accumulation of foul matter, food, microorganisms, and epithelial elements on the teeth and gums is referred to as swords. Skill 30-9 describes assessment of the mouth and oropharynx. Figure 30-17 anatomic structures of the mouth. Orpharynx. Parotid gland. Stenson's duct opening. Palatine tonsil. Fauces. Uvula. Sublingual gland. Wharton's duct opening. Submandibular gland. Assessment normal findings deviations from normal. Lips and buccal mucosa 6. Inspect the outer lips for symmetry of contour, color, and texture. Ask the client to purse the lips as if to whistle. Uniform pink color, darker, example, bluish hue, in Mediterranean groups and dark-skinned clients, soft, moist, smooth texture symmetry of contour ability to purse lips. Pallor, cyanosis blisters, generalized or localized swelling, fissures, crusts, or scales, may result from excessive moisture, nutritional deficiency, or fluid deficit, inability to purse lips, may indicate facial nerve damage. 7. Inspect and palpate the inner lips and buccal mucosa for color, moisture, texture, and the presence of lesions. Apply clean gloves. Uniform pink color, freckled brown pigmentation in dark-skinned clients, pallor, leukoplakia, white patches, red, bleeding. Planning if possible, arrange for the client to sit with the head against a firm surface, such as a headrest or examination table. This makes it easier for the client to hold the head still during the examination. Interprofessional practice. Assessing the mouth and oropharynx is within the scope of practice for many healthcare providers other than nurses, such as physician assistants. Although these providers may verbally communicate their findings and plan to other healthcare team members, the nurse must also know where to locate their documentation in the client's medical record. Equipment: clean gloves, tongue depressor 2 times 2 gauze pads, pen light. Delegation. Due to the substantial knowledge and skill required, assessment of the mouth and oropharynx is not delegated to UAP. However, many aspects are observed during usual care and may be recorded by individuals other than the nurse. Abnormal findings must be validated and interpreted by the nurse. Implementation performance 1. Prior to performing the procedure, introduce self and verify the client's identity using agency protocol. Explain to the client what you are going to do, why it is necessary, and how he or she can participate. Discuss how the results will be used in planning further care or treatments. 2. Perform hand hygiene and observe other appropriate infection prevention procedures. 3. Provide for client privacy. 4. Inquire if the client has any history of the following: routine pattern of dental care, last visit to dentist, length of time ulcers or other lesions have been present, denture discomfort, medications client is receiving. 5. Position the client comfortably, seated if possible. Assessing the mouth and oropharynx. Skill 30-9. M30_Berm 4362_10_SE_CH 30.IND 546 April 12, 11:03 a.m. Chapter 30 Health Assessment 547. Number 153613 CUST, Pearson O. Berman PG Number 547 Title, Cozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Continued on page 548. Assessing the mouth and oropharynx, continued. Skill 30-9. Inspecting the mucosa of the lower lip. Assessment: normal findings, deviations from normal. Ask the client to relax the mouth and, for better visualization, pull the lip outward and away from the teeth. Moist, smooth, soft, glistening, and elastic texture, drier oral mucosa in older clients due to decreased salivation. Excessive dryness, mucosal cysts, irritations from dentures, abrasions, ulcerations, nodules. Grasp the lip on each side between the thumb and index finger. Teeth and gums. 8. Inspect the teeth and gums while examine the inner lips and buccal mucosa. Ask the client to open the mouth. Using a tongue depressor, retract the cheek. View the surface buccal mucosa from top to bottom and back to front. A flashlight or pen light will help illuminate the surface. Repeat the procedure for the other side. 32 Adult teeth. Missing teeth, ill-fitting dentures, smooth, white, shiny tooth enamel. Pink gums, bluish or brown patches in dark-skinned clients, moist, firm texture to gums. No retraction of gums. Brown or black discoloration of the enamel may indicate staining or the presence of caries, excessively red gums. Spongy texture, bleeding, tenderness, may indicate periodontal disease, receding, atrophied gums, swelling that. Examine the back teeth. For proper partially covers the teeth vision of the molars, use the index fingers of both hands to retract the cheek. Ask the client to relax the lips and first close, then open the jaw. Rationale: closing the jaw assists in observation of tooth alignment and loss of teeth. Opening the jaw assists in observation of dental fillings and caries. Observe the number of teeth, tooth color, the state of fillings, dental caries, and tartar along the base of the teeth. Note the presence and fit of partial or complete dentures. Inspect the gums around the molars. Observe for bleeding, color, retraction, pulling away from the teeth, edema, and lesions. 9. Inspect the dentures. Ask the client to remove complete or partial dentures. Inspect their condition, noting in particular broken or worn areas. Smooth, intact dentures, ill-fitting dentures, irritated and excoriated area under dentures. Tongue/floor of the mouth. 10. Inspect the surface of the tongue for position, color, and texture. Ask the client to protrude the tongue. Central position, pink color, some brown pigmentation on tongue borders in dark-skinned clients, moist, slightly rough, thin whitish coating, smooth, lateral margins, no lesions, raised papillae, taste buds. Deviated from center, may indicate damage to hypoglossal, 12th cranial, nerve, excessive trembling, smooth red tongue, may indicate iron, vitamin B12, or vitamin B3 deficiency. Dry, furry tongue, associated with fluid deficit, white coating, may be oral yeast infection, nodes, ulcerations, discolorations, white or red areas, areas of tenderness. Inspecting the buccal mucosa using a tongue depressor. Inspecting the back teeth. M30_berm 4360_10_SE_CH30.IND547 April 12, 11:03 a.m. Number 153613 CUST, Pearsono, Berman PG number 548 title, Cozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K /Normal Design Services of S4 Carlisle Publishing Services. 548 Unit 7 Assessing Health. Assessing the mouth and oropharynx, continued. Skill 30-9. Lifespan considerations assessing the mouth and oropharynx. Infants inspect the palate and uvula for a cleft. A bifid, forked, uvula may indicate an unsuspected cleft palate, i.e., a cleft in the cartilage that is covered by skin. Newborns may have a pearly white nodule on their gums, which resolves without treatment. The first teeth erupt at about 6 to 7 months of age. Assess for dental hygiene. Parents should cleanse the infant's teeth daily with a soft cloth or soft toothbrush. Fluoride supplements should be given by 6 months if the child's drinking water contains less than 0.3 parts per million ppm fluoride. Children should see a dentist by 1 year of age. Children tooth development should be appropriate for age. White spots on the teeth may indicate excessive fluoride ingestion. Assessment normal findings deviations from normal. 11. Inspect tongue movement. Ask the client to roll the tongue upward and move it from side to side. Moves freely, no tenderness restricted mobility. 12. Inspect the base of the tongue, the mouth floor, and the frenulum. Ask the client to place the tip of the tongue against the roof of the mouth. Smooth tongue base with prominent veins swelling, ulceration. Palates and uvula. 13. Inspect the hard and soft palate for color, shape, texture, and the presence of bony prominences. Ask the client to open the mouth wide and tilt the head backward. Then, depress tongue with a tongue depressor as necessary, and use a pen light for appropriate visualization. Light pink, smooth, soft palate. Lighter pink, hard palate, more irregular texture. Discoloration, example, jaundice or pallor, palates the same color. Irritations, exostoses, bony growths, growing from the hard palate. 14. Inspect the uvula for position and mobility while examining the palates. To observe the uvula, ask the client to say ah so that the soft palate rises. Positioned in midline of soft palate, rises during vocalization. Deviation to one side from tumor or trauma, immobility, may indicate damage to trigeminal, 5th cranial, nerve or vagus, 10th cranial, nerve. Oropharynx and tonsils. 15. Inspect the oropharynx for color and texture. Inspect one side at a time to avoid eliciting the gag response. To expose one side of the oropharynx, press a tongue depressor against the tongue on the same side about halfway back while the client tilts the head back and opens the mouth wide. Use a pen light for illumination if needed. Pink and smooth posterior wall. Reddened or edematous, presence of lesions, plaques, or drainage. 16. Inspect the tonsils, behind the fauces, for color, discharge, and size. Pink and smooth, no discharge of normal size or not visible. Grade 1, normal. The tonsils are behind the tonsillar pillars, the soft structures supporting the soft palate. Inflamed, presence of discharge. Swollen. Grade 2, the tonsils are between the pillars and the uvula. Grade 3, the tonsils touch the uvula. Grade 4, one or both tonsils extend to the midline of the oropharynx. 17. Remove and discard gloves. Performed hand hygiene. 18. Document findings in the client record using printed or electronic forms or checklists supplemented by narrative notes when appropriate. Evaluation. Perform a detailed follow-up examination of other systems based on findings that deviated from expected or normal for the client. Relate findings to previous assessment data if available. Report deviations from expected or normal findings to the primary care provider. M30_BERM 4362_10_SE_CH30.IND 548 April 12, 11:03 a.m. Chapter 30 Health Assessment 549. Number 153613 CUST, Pearson, Berman PG. Number 549 Title, Cozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Figure 30 to 18 Major muscles of the neck. Insertion, mastoid process and occipital bone. Trapezius muscle. Posterior triangle. Sternocleidomastoid muscle. Clavicle. Origin, manubrium of sternum and medial third of clavicle. Anterior triangle. Figure 30 to 19 Structures of the neck. Hyoid bone. Thyroid cartilage. Sternocleidomastoid muscle. Cricoid cartilage. Lobe isthmus. Trachea. Clavicle. Suprasternal notch. Manubrium of sternum. Thyroid gland. Lifespan considerations assessing the mouth and oropharynx, continued. Drooling is common up to 2 years of age. The tonsils are normally larger in children than in adults and commonly extend beyond the palatine arch until the age of 11 or 12 years. Older adults, the oral mucosa may be drier than that of younger people because of decreased salivary gland activity. Decreased salivation occurs in older people taking prescribed medications such as antidepressants, antihistamines, decongestants, diuretics, antihypertensives, tranquilizers, antispasmodics, and antineoplastics. Extreme dryness is associated with dehydration. Some receding of the gums occurs, giving an appearance of increased toothiness. Taste sensations diminish. Sweet and salty tastes are lost first. Older people may add more salt and sugar to food than they did when they were younger. Diminished taste sensation is due to atrophy of the taste buds and a decreased sense of smell. It indicates diminished function of the fifth and seventh cranial nerves. Tiny purple or bluish-black swollen areas, varicosities, under the tongue, known as caviar spots, are not uncommon. The teeth may show signs of staining, erosion, chipping, and abrasions due to loss of dentin. Medicare does not cover dental cleanings or treatments. Older adults with limited incomes may delay or avoid professional dental care. Tooth loss occurs as a result of dental disease, but is preventable with good dental hygiene. Check that full or removable partial dentures fit properly. Bone loss and weight loss or gain can change the way these prosthetics fit. The gag response may be slightly sluggish. Older adults who are homebound or are in long-term care facilities often have teeth or dentures in need of repair, due to the difficulty of obtaining dental care in these situations. Do a thorough assessment of missing teeth and those in need of repair, whether they are natural teeth or dentures. Home care considerations assessing the mouth and oropharynx. Although clients may be sensitive to discussion of their personal hygiene practices, use the assessment as an opportunity to provide teaching regarding appropriate oral and dental care for the entire family. Refer clients to a dentist if indicated. Patient-centered care. Neck. Examination of the neck includes the muscles, lymph nodes, trachea, thyroid gland, carotid arteries, and jugular veins. Areas of the neck are defined by the sternocleidomastoid muscles, which divide each side of the neck into two triangles, the anterior and posterior, figure 30 to 18. The trachea, thyroid gland, anterior cervical nodes, and carotid artery lie within the anterior triangle, figure 30 to 19. The carotid artery runs parallel and anterior to the sternocleidomastoid muscle. The posterior lymph nodes lie within the posterior triangle, figure 30 to 20. Each sternocleidomastoid muscle extends from the upper sternum and the medial third of the clavicle to the mastoid process of the temporal bone behind the ear. These muscles turn and laterally flex the head. Each trapezius muscle extends from the occipital bone of the skull to the lateral third of the clavicle. These muscles draw the head to the side and back, elevate the chin, and elevate the shoulders to shrug them. Lymph nodes in the neck that collect lymph from the head and neck structures are grouped serially and referred to as chains. See figure 30 to 20 and table 30 to 6. The deep cervical. M30_Berm 4360_10_SE_CH30.IND549 April 12, 11:03 a.m. Number 153613 CUST, Pearsono, Berman PG number 550 title, Cozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K /Normal Design Services of S4 Carlisle Publishing Services. 550 Unit 7 Assessing Health. Chain is not shown in figure 30 to 20 because it lies beneath the sternocleidomastoid muscle. Skill 30 to 10 describes how to assess the neck.